joining. Welcome. Today's topic in the community of practice call will be high KDPI kidneys for transplant. And we have some great presenters from the Medical University of South Carolina. I'm going to present a couple of slides just about what the CARES contractor is, what we do, and then we'll jump right into the presentation and our guest speakers. Next slide. All right, who is CARES? What do we do? We are the Kidney Health Analytics and Responsive Emergency Support Contractor. So we are a national contract funded by CMS. And what we do is we support the kidney community through various different tasks. We work with community engagement and partnerships. We have a role in emergency response and preparedness, data analytics, reporting, patient and family engagement, and we provide technical assistance and information sharing. If you're familiar with the ESRD contracts prior, what was the National Coordinating Center and the Kidney Community Emergency Response, this is what sort of morphed those two contracts into a new contract that's a bit different in some ways. So the goal of this work is to strengthen the kidney community through collaboration, data solutions, education, technical assistance, and really bringing the community together and sharing best practices. Next slide. This is the CARES team. I'm not going to go through everyone, but you'll see us from time to time on different calls, people hosting. Today, I'm joined by Laura Mankin and Laura Edwards, who are, our rest of the team is also on the call, but Laura will be helping host and fielding any questions in the chat. Next slide. So why a community of practice call and why do we even have them? I think this slide really captures what we hope these calls become. We know there's a tremendous amount of expertise in the community, and one of our goals is to create opportunities to bring that expertise together. These calls are designed to connect the ESRD networks, the providers, patients, partners, stakeholders, to share ideas, best practices, lessons learned, and practical solutions. This isn't meant to be a one-time presentation. We hope all these calls become a place where we can ask questions and be very collaborative. This is the first in a monthly series and would really like your input. Or if you have ideas or speakers to recommend or topics to recommend, we would love to hear that. But at the end of the day, our goal is simple with these calls. It is to strengthen the collaboration across the kidney community. Next slide. A little bit of meeting guidelines, sort of the basics. Please keep your microphone muted when you're speaking. Please use the chat feature for questions. We're going to save those questions for the end. And if you put them in, we'll have Laura kind of helping us at the end there. The session is being recorded and the presentation materials will be available after the webinar. And if you have any technical issues, also put those in the chat so someone can kind of side chat you and help you out. Next slide. So today's presentation is optimizing use of high KDPI kidneys for transplant. Presenting today will be Dr. Anand. He is a transplant nephrologist and medical director of transplant services at MUSC Health Lancaster's transplant program, Mid-Carolinas. He specializes in kidney transplantation and has played a key role in expanding access to transplant across the region, including the growth of living donor kidney transplantation. Dr. Anand's clinical interests include transplant outcomes, transplant policy, and improving access to kidney transplant in the underserved communities. Dr. Okese is our next speaker, is a transplant surgeon at MUSC Health Lancaster and surgical director of the kidney transplant program. He specializes in abdominal organ transplantation with particular expertise in kidney transplant and vascular access procedures for dialysis patients. He has been instrumental in the development of growth of the MUSC's Lancaster transplant program and is committed to advancing surgical care for patients with end-stage renal disease. And Dr. Adrienne Carlson is a PharmD. She's a transplant pharmacist at MUSC Health Lancaster. She works closely with a multidisciplinary team to optimize immunosuppressants, support medication access, and improve long-term outcomes for kidney transplant recipients. Dr. Carlson's professional interests include transplant pharmacotherapy, patient education, expanding innovative patient-centered care with transplant programs. I'm really pleased and actually thrilled and honored to have these speakers with us. Now I'm going to hand it off to Dr. Anand.
I want to thank you for bringing us here. I've been working with iPro for the last 5 years or so, and congratulations on your contract. We're glad that we are the first people chosen to give the talk. Uh, and we all work at MUSC Mid Carolinas. We are a small hospital with a large transplant center in a rural area. Next slide, please. These are the disclosures. None of the products that I have, conflicts will be discussed here. Next slide, please. So this is what we have said, that how to increase the organ acceptance, and that's important. As you can see, the kidney is really cold, so we want it to get to a warm body. Next slide, please. Just to talk about quick facts about CKD, there are a lot of people who have got chronic kidney disease, and 90% of patients don't even know that they have got diminished kidney function. 1 in 3 patients, three adults have kidney disease. And when you look globally, not only just in the US, and across the globe, the CKD incidence is going up, and minorities are at higher risk when you compare to Caucasians, especially African Americans. A lot of people on dialysis, more than 500,000 of patients are on dialysis. And today, although it says 230,000, that number has been updated to about 280,000 patients with working kidney transplants are part of the US population, and 100,000 patients waitlisted in the US and about 1,400 in the state of South Carolina. Next slide, please. And if you see the prevalence of ESRD and stage kidney disease, this is up to 2015 to 2018. You can see that African American population is, there is white population, there is African American, American Indian or Alaskan, but the African Americans are overly represented because the higher risk of kidney disease in this population. And if you see similarly in South Carolina, the African Americans are even more higher, the numbers are higher, even though in general population, their number is lower. Goes to show that the risk of end-stage kidney disease and chronic kidney disease is very high in African American population. Next slide, please. And when you look at the death rates in compared to US and South Carolina, the death rates are pretty high in South Carolina compared to the whole United States. And again, this data is from 2018. And this is true for every age group if you look at it. So things have changed recently because of the fact that we have better care available, more hospitals, and we have got 3 transplant centers now compared to 2018. Next slide, please. This is a very important slide, important not only for general population, but also for CMS, also for, transplant nephrologists, that kidney transplant is a treatment, it's not a cure, right? Just like dialysis is a treatment. Patient sits on dialysis for a number of hours. Similarly, transplant is also a treatment. It's not a cure. It's not like you get transplant, now you don't have kidney disease. You still have kidney disease. You still have to manage yourself. All those things are very, very true. For this to happen, either you need a cat donor or a living donor transplant. Transplant workup takes time and eligibility strict based on which center you go. Transplant is a major surgery. I tell people it's not walk in the park, and you're not going to become a superman or superwoman after transplant. So these things are very important to remember, and the meds have to be taken daily. And if you're not taking your meds, there is a very high risk of rejection. Next slide, please. Again, just a quick refresher. You've got living donor transplant. Again, not everybody has a living donor transplant, especially African American population. We ought to work with them, make sure they have living donor champions so that they can work and get living donors. Cadaver donor transplants, waiting lists are longer. Outcomes are based on quality of donors. And then we have got brain death or donation after cardiac death. And in the last 2 to 3 years, we have seen that DCD donations, which is donation after cardiac death, has become the major pathway of transplantation, and donation after brain death has decreased. We used to get a lot of patients from the opioid epidemic, and luckily for general population, the death rates of opioid death rates have decreased 20% from 2024 to 2025, which is very good overall. Preemptive transplant, we tell you, is the goal, so that people get listed early. They never go on dialysis, but not everybody gets that lucky, and most of patients get transplanted after starting dialysis. Next slide, please. We just said that I'm not going to spend a lot of time on it, that living donor is the best treatment for kidney failure. And if you see here, people who get living donor, they're living longer at 10 years than anybody else. Next slide, please. Now, kidney allocation has changed over the past 12, 13 years. The most important thing is that all allocation policies should follow OPTN final rule, which is equitable allocation of cadaveric organs. The allocation policy was changed recently in March 2021. That was made, DSAs were removed, new allocation policy was started, and kidneys were allocated to 250 nautical mile radius, which is about 280 miles. Rather than you being attached to a OPO, now you are attached to multiple OPOs, which are close by, and the kidneys are given nationally. And the purpose is to make sure that we can increase the utilization of the organs. Next slide, please. From our transplant center, we are a 80-bed rural suburban transplant program, which is about 25 miles out of Charlotte. We started doing transplants in July of 2022. Most recently, we have done about 400 kidneys, and our acceptance ratio for kidneys based on SRTR data is 2.55. Next slide, please. So for MUSC and South Carolina, we're just saying double the hope, because we have got 2 transplant centers in 2 ends of the state, making sure that we can capture and help patients in these states. And the area that we are serving, which is over here, it's a very poor area, even though it's right outside of Charlotte. So opening a transplant center here meant that we can help a lot of patients who otherwise could not travel to Charleston. Next slide, please. Now, when you look at the goal for kidney transplant programs, and this slide is courtesy of Dr. Francis Wang, who is in New Jersey. Every transplant program has 2 main missions. You want to do more transplants, you want to do them well. What does that mean? That you've got good outcomes and you're taking care of these patients. So you want to increase volume, you want to keep quality, and you want to make sure that your costs are contained so that you can continue to transplant. And at the same time, you can do some research as well. Next slide, please. So the reason that we were invited to speak here is it speaks for what you see here. This is our SRTR data. The chance that you will get kidney quickly at our center is pretty high, and our 1-year outcomes are decent as well. Next slide, please. I think this slide got repeated. Next slide, please. So this goes to show what are our transplant rates. The expected rate is somewhere here, which is about 30, and the number of transplants we are doing is about close to 90. As I was saying, it's about 2.5, 2.6 times the expected ratio. And if you see in the US versus region and OPO, we are about 2.5 times doing more transplants than expected. Next slide, please. And this is the transplant rates. Similarly here, it tells you the same data. Next slide, please. And again, a very important point is that if you don't use these kidneys, the high KDPI kidneys, they all go to trash. And we don't want the organs to be discarded. We want to make sure that the kidneys are used. This paper is from 2024. It shows you that the standard criteria donor or this is, think of it as, high versus low KDPI, where the organ discard is happening. You're seeing more discard in ECD, or in this case, KDPI above 85, and that's pretty much standard here. And similarly here, you will see that higher KDPI organs have more discard rates than not. And what we see here is that the biopsy rates for high KDPI organs have gone up. And if you have got higher glomerulosclerosis score, the chances of kidney being discarded goes higher. Next slide, please. Now, what are we doing different than others? One of the things you can do is you can use the CARE tool. Again, this slide is given to us by Dr. Francis Wang. The CARE tool, what it gives you is basic donor information. It gives you age, KDPI, DCD or DBD, creatinine, and what's a percent of glomerulosclerosis. And it tells you if the kidney that you declined at your center, you can go back and look at it, and it will tell you if the kidney got accepted, at what sequence it got accepted, and if other center declined it, why it was declined. And it tells you the outcome of that kidney at discharge, 6 months, 12 months, which is pretty neat, that if you're ever concerned about, hey, what happened with that kidney that we were not sure about, should we go back and look? So you can go back and look at it and say, oh, well, this kidney did well. If this kidney did well, maybe next time when the kidney comes around, we ought to take this kidney and not say no for that kidney. Or sometimes you're like, oh, we're not going to touch this kidney with a 10-foot pole, and then you can go back and confirm that you were okay, that it will just reinforce you not to take those kidneys. So the CARE tool in UNOS is a great tool. What it does not tell you is the detailed past medical history, inpatient course, and post-clamp information. So you have to go back, look at all that information by yourself. But if you want to look at and improve where your center is, CARE tool is a great way to start. Next slide, please. What have we done together that has made us better as a program? Surgeons and nephrologists are on call together, Dr. Al-Casey, myself, or whoever is there. So always a surgeon and a nephrologist are together. We look at the offer together, then we review the recipients together to make sure that we have an idea as to who is going into the OR and what to expect they're coming out. When we are doing all this in the morning, we come back to the office, we get hold of our pharmacist, we tell them this is what's going on. Maybe we need to do a CNI minimization. So it's a very collaborative environment where we all discuss things and make sure that we do things appropriately. And then anatomy and specific concerns, if there are, the surgeons take care of that. And if there are biopsy report issues, then the nephrologists do that. And then it becomes important to ask for waivers. And I saw there was a question about waivers. It depends what's going on, and we'll give you some examples as to where we have asked for waivers and what kind of waivers we ask. Sometimes we ask for pump waivers. Sometimes we ask for anatomy waivers. There are times we have asked for, biopsy waivers, that, hey, we're going to bring the kidney in here. We will biopsy it ourselves. If the biopsy is okay, we'll transplant. Otherwise, we will not. So those are the things that we ask for waivers. Next slide, please. And I'm going to let Dr. Al-Casey take over from here.
Yeah, thank you, everybody. Thank you for having me today. And thank you, Prince, for letting me talk about it. So when we talk about how to use more kidney, there is many perspectives we have to think about it. In transplant, it's not always you got a 20-year-old normal creatinine donor with perfect anatomy. The fact that you have to go between different kind of kidneys with different kind of damages and you have to keep your mind open for different options to increase your volume. As Dr. Prince said, we are a small program. We start with a small list. If I'm trying to wait for every perfect kidney, and I'm not saying the other kidney are not perfect, but we have a rule to say we put the right kidney in the right person. For example, if you have a high KDPI kidney, like 65-year-old kidney or 70-year-old kidney, I don't mind to put it in a 7-year-old patient, but I will not put it in a 20-year-old patient. So there is many things to think about it when we go for transplant. One example is this kidney that you can see, obviously, this is the aorta, and you can see like 2/3 of the aorta is black. And I wish if anybody can feel it, it was like bone hard, And the problem when we get the call, the kidney is in the high KDPI, but it's not like above 85. But if you look at it, like 63-year-old donor, initial creatinine is 1.7, peak is 2.5, and terminal creatinine is okay. Biopsy is good, and that's the only, not the only thing. That's one of the things that keep me on this kidney. But pump number over 8 hours is bad. So many people will say, like, probably this kidney have vascular damage, or this kidney have some issues, where we will pass on it. That's the easy answer, just pass on the kidney. Now, in our part, what we do, we say, like, we don't mind to do extra work, extra job. We ask the OBO, let me get a pump waiver and anatomy waiver, and I will look at it. Now, behind the scene, what I've been doing, I look to the mate kidney, I looked at the pump number are great. So that's say, like, there is something odd about this kidney. So when we get the kidney, and what I did, while the kidney on the pump, I just played with the pump. I found that the kidney was put in the pump twisted. So the artery was twisted on the kidney. So when I untwist the kidney, the pump numbers went to be perfect. Flow is 120 and resistance 0.2. Now, still have a problem that the orifice of the kidney or of the aorta is bad. So in our recipient, we have to make sure that the recipient have normal vessels or good vessels to get this kidney done. So I have to, again, test the kidney with the flow. It went well. Then we have to cut the cuff and use it as a living donor. The patient now, which we did the transplant to, her creatinine, I think it's trending down nicely. It's from 8 down to 5 to 3 to 2. And we saw her, I think yesterday, it's below 2. So that's one of the things we can do, like, ask the OBO for waivers, which makes sense. If you have bad pump number, get that and try to figure it out yourself. You may find these things. Even if there is a problem in the vessels, there may be in the aorta, but maybe the renal artery is in a good shape. Next slide. So that's what we went to. We used the kidney, and the kidney went well. Next slide. Now, some days things doesn't go well as you think, like this case was from 2 months ago. We got the same thing, same parameter, kidney with the relatively high KDPI, a little bit older donor. We get the kidney with the bad resistance. We get the kidney, and we figure out there is dissection on the artery. So we could not use this kidney. But again, like if you do it every now and then, I will say probably 70% of the kidney we got with the pump neighbor or anatomy waiver, we end up using them, Otherwise, these kidneys will be, maybe sent to the trash if we don't use it. So next slide. Next one. Another case that interesting. There was a 13-year-old donor with normal creatinine and no biopsy, of course, but the kidney was declined due to the anatomy damage in the OR. So the previous accepting centers say, like, there is significant damage on the hilum of the kidney or the vein, and they were concerned. So we got the call from the OBO, like, hey, we have this situation, this kidney, there is suspected bad damage. What do you think you can use it? Now, again, the easy answers you will say no. Like, why have to use the kidney? Somebody else decline it. But we say we do extra job. So honestly, Dr. Prince called one of our friends, the recovering surgeon, and he confirmed that he didn't remember any issues. We said, let's get the kidney with anatomy waiver. We brought the kidney, and we stared at the kidney for maybe 30 minutes to find any problems. The only thing we found is just extra dissection on the hilum. And we transplant the kidney. The recipient's doing great. Creatinine is less than 1, and it's doing well. So bottom line, from what I'm saying, first try to do extra work. It will be sometimes painful to spend extra time in the OR or get like extra phone call, because once you say yes, you will probably have like sleepless night, between coordinating the kidney, the situation, the OR. The second thing is, give a kidney another chance. Like if somebody say no, you know, that we think there is a damage, we think it's kidney is not usable, bring the kidney yourself and examine the kidney yourself. And there is, again, as I said, we don't mind to use kidney with damage if we are ourselves think, and we say like ourselves, sometimes we get kidney, I mean, many centers decline for damage and we bring it and it works well. Transected veins, transected artery. We use high KDPI kidney. We use dual kidney. Like, you know, if the kidney have from older donor and we don't think one kidney would be enough, we ask for dual kidney. And many times we got it. Like from out of the 400 kidney that we did, I would say probably 10 or 12 kidney are dual kidney. And most of the patients are doing well. And again, communication is really important. And the most important thing, even we do all of that, we keep in our mind the safety of our patient. So when we do that, we don't like, you know, just put any kidney in our patient. No. As Dr. Prince say, you know, we both, it's like a team. I look deep in the kidney, he look deep in the right recipient, and we do, you know, the same thing. And we call Adrian like, hey, we think this kidney will benefit from CNI minimization. So it's a teamwork. And again, it's extra homework, extra effort, but it does pay well by the end of the day. And from here, I think I will go back to Dr. Prince for the next slide.
Next slide, please. So if you don't have a pathologist friend, please make one, okay? We always review the biopsies ourselves, the surgeon and the nephrologist. We make sure everything is okay. If your OPO uses Specialist Direct, there is a small QR code underneath the biopsy results. You can use that QR code and share that QR code with your pathologist, or share the link with your pathologist, and they can tell you what's going on. One of my friends who's at Arcana Lab, Dr. Shri Sharma, he's a very good friend. So I have texted him the information like, hey, Shri, can you please take a look at it? And he has helped saying that, yes, this is a good kidney, take it, or no, I won't use this kidney. And sometimes we have done the same with our MUSC pathologist, like, I wish you, could you please see and review the biopsy if it's useful or not. So having a pathologist friend goes a long way, more than you can even imagine. So always, not only post, but pre as well. Next slide, please. Recipient selection is key as well. As Dr. Al-Kaisi said, that we always make sure that the patients that we're bringing in, they're appropriate. If the patient is listed, they should be ready for transplant. You have a patient active, you don't have to think 5 times, oh my God, can I bring this patient or not? So that's the key when you're doing high KDPI organs, because essentially sometimes you cannot use the kidney for the top patient, but you have to bring patient who the kidney is appropriate for. As Dr. Al-Kaisi said, you cannot use a 70-year-old kidney for a 20-year patient. That's not appropriate in any case. So, and we do have our specific on-call notes that will tell us what needs to be done. Sometimes we'll say, okay, patient has, you know, psychological issues, CNI minimization, or just start de novo Bella, or right versus left side due to calcification. That becomes very important for the surgeons that day. And I'm gonna hand over here to Adrian so that she can take us home. Quickly, I forgot to tell you, early biopsies are needed. We do low fluid resuscitation if the patient is going to have DGF. And believe it or not, Lasix and Lokelmas are your good friends. That is very, very important, you know. And we have started using some 35 lives kidneys that we didn't do before. Adrian, thank you for taking over from here.
Thank you, Dr. Anand, and thank you to iPro for the opportunity to speak today. After kidney transplant, we sometimes find that our patients cannot tolerate traditional anti-rejection medications. Calcineurin inhibitors such as tacrolimus are our standard of care, and they're highly effective at preventing rejection. But they do have their limitations in the fact that they can cause renal vasoconstriction, which may reduce blood flow to the transplanted kidney. So in select patients, especially our patients receiving high KDPI organs, lowering CNI levels may help to preserve or improve kidney function. Next slide, please. We have 2 main alternatives to our traditional tacrolimus-based therapies. These are mTOR inhibitors, such as everolimus or sirolimus, and our co-stimulatory blockers, such as belatacept. These approaches represent two different strategies. So with everolimus or sirolimus, we can continue tacrolimus, but we typically use tacrolimus in a lower dose. And we call this CNI minimization that you've heard my other two colleagues discuss during this talk. With belatacept, tacrolimus can eventually be replaced altogether. So each strategy has its own unique advantages and disadvantages, which we'll discuss. Next slide, please. First, we will discuss our mTOR inhibitors. So as mentioned, these agents allow us to reduce our dose of tacrolimus, which may lead to decreased side effects for our patients. And studies have shown that when we are able to switch early after transplant, kidney function is often preserved and may even improve in comparison to our traditional methods with standard dose tacrolimus. There's also less risk for viral infections and malignancy risk with mTOR inhibitors, and so this can be advantageous in certain patient populations. Next slide, please. A potential disadvantages of everolimus and sirolimus is their side effect profile. So even though these are good drugs that'll help us out in some ways, we can see some side effects such as proteinuria, delayed wound healing, and oral ulcers, among some others. So whenever we're switching our patients to these agents, we have to be very careful with our patient selection, and we have to follow them closely. That becomes very essential. Clinical trials have continuation rates in mTORs at about 30% due to side effects. So not everybody tolerates these agents, but we also have to be vigilant about an increased risk for rejection in these agents. They're typically used in patients who have a low risk for rejection. Next slide, please. Actually, I think go back one slide. I think now we're on our belatacept. Yes, thank you. So our second option is belatacept-based therapy. So one of its unique advantages is that after a short period of overlap with tacrolimus, we can actually remove tacrolimus from the patient's medication regimen completely. So this can be a game changer for us. And clinical trials have shown sustained improvement in kidney function in these patients that are treated with belatacept. Another advantage of belatacept is that you can avoid many of the metabolic side effects that we see with both tacrolimus and mTOR inhibitors. These are things such as high blood pressure, dyslipidemia, and hyperglycemia. And this is key because cardiovascular disease remains the leading cause of death after kidney transplant. So anything that we can do to help out with any type of metabolic side effects is crucial. Belatacept can also be easier for some patients to manage because it's a fixed dose. It's given as an IV. So in patients, especially those that have a large pill burden, which is the majority of our patient population, this helps to reduce pill burden and the need for dose adjustments because that's one less medication that we have to monitor drug levels of and make frequent dose changes. Next slide, please. On the other hand, belatacept has been associated with an increased risk of early T-cell mediated rejection. There's also a higher risk for certain types of infections, including BK virus and CMV infections. So we have to be very careful about our patient selection for this agent. We typically at our center do not start patients who are at high risk for CMV or who have active BK infections. Another thing to think about with belatacept is that it's administered IV. So access to an infusion center can be a challenge for some patients, especially if they live in a rural community or if they're older and have difficulty with transportation. And one of the biggest things that we battle with is cost. This medication can be expensive, and ensuring insurance coverage and affordability is critical before making the transition to belatacept. Next slide, please. So how do we choose which strategy for our patients? There are a lot of factors that we weigh in whenever we're discussing with each other about, okay, we need to minimize our CNI. What exactly do we need to do? So first, we look at the reason as to why the patient isn't tolerating a calcineurin inhibitor. Sometimes we find that even in addition to some renal dysfunction, a patient might be having altered mental status. We will see this occasionally in our older folks as well, and those may be the folks who are getting your high KDPI organs. And in those folks, belatacept may be the best alternative because we're able to take away tacrolimus altogether. We also weigh the patient's infection risk and malignancy risk, as everolimus has less risk than belatacept for those. Belatacept is actually contraindicated in EBV negative patients, so we always have to confirm the patient's EBV status before we can even consider converting to that agent. And unfortunately, as I mentioned before, cost is one of the biggest drivers of which regimen we can actually go with. So this insurance status and copays play a big role in what our patients are able to do. Ultimately, this is a decision that's considered after a discussion with the patient as well, and weighing the options with them. So we involve our patients with the decision making as well. Next slide, please. So in summary, transplanting high KDPI kidneys can be successful when you choose the right kidney for the right patient. Much of our success here at MUSC Lancaster is due to the fact that we use a true multidisciplinary approach, as you can see from our talk. Caring for these patients often requires thoughtful, creative problem solving, and we rely on each other's strengths for the benefit of the patient. Thank you for taking the time to listen to our talk today.
Thank you, doctors. I appreciate your presentation. That was wonderful. I see Dr. Anand was busy answering the questions in the chat. Did anyone have any more additional questions? And did Dr. Anand, did you want to expand on any of those responses, or were you good?
So there's a question about the waivers. So waivers are not given by OPTN, or UNOS. The waivers are given by the OPOs, and it depends as to why we're asking the waivers. In the prior cases, you have seen that Dr. Casey asked for the anatomy and pump waivers to make sure that if the kidney's there, we move the kidney and the numbers are still bad, or the kidney is so highly calcified that we cannot use it. In that case, you want to make sure you have the waiver. What waiver means is that in case you bring the kidney or the organ to your center and you're not able to use it, then you do not have to pay the bill for the organ, because all of us, we know that the cost of organ acquisition has increased significantly in the past 5 years. The average cost of a kidney right now is about $55,000 to $60,000. So if you are stuck with that cost, it's a lot of cost, and your administrators might not be happy. So in that situation, that's why you ask the waiver. And if you work with your OPOs, like around 5 OPOs in the area, we work with them all the time, and we are their last hope. So when we ask for a waiver, they know that we don't abuse that, waiver. We try to use the organ. Our main goal is to use that organ, and they're very happy to provide the waiver. And there are times when we have said that we cannot use this organ, and they have said, okay, don't worry about it. We're not going to try to place it. Occasionally they have tried to place it unsuccessfully, but most of the time they listen to us. And then there was a question about how patients can influence their center's organ offer acceptance. When the patients come to us, Dr. Casey, our coordinators, myself, and all other partners that we have, Dr. Azim, Dr. Daoud, Dr. Amar, all of us, we sit down and we spend a lot of time explaining the patients what high KDPI kidneys are, what are KDPI is not know all, right? Because KDPI does not have the biopsy of the information. It does not have biopsy, does not tell you what the anatomical issues are and things like that. And sometimes high creatinine can drive the KDPI or other things. So when we accept the kidney, we look at everything, and we tell them that if we are looking at the kidney, the surgeon, the nephrologist, everybody's looking at the kidney. And that's when we accept the kidney. And when they hear it from everybody, they have a little more confidence in saying yes. But education is the key. We have seen, although sometimes, that some patients will come with this notion that they do not want high KDPI organs because that's what has been told by their nephrologists. So the education is not only needed for transplants patients, but also for general nephrologists. So what you guys are doing today in a webinar like this, it's great, but we ought to make sure that our general nephrologists are also involved in this, so that they also know that, hey, high KDPI organs work, and KDPI is not one know all kind of situation. Mo, do you have to add anything else to what I said?
Yeah, thank you so much, Prince. One thing I want to add, previously, before you changed the criteria for or the parameter for KDPI, when they took off hepatitis C and African American ethnicity, we have way more high KDPI kidneys. And to be honest, for me, KDPI is just a number. It can go, between different parameters that you have to look at it. And we've been taking a lot of advantage for high KDPI because we've been looking for different perspective. We look for the anatomy, we look for the kidney function, we look for the biopsy. So these things can means more rather than the high KDPI, which I'm not saying, it doesn't help, but sometimes it's maybe false, like falsely high or falsely low. So you have to look to the big picture.
Thank you very much. I have a quick question. So where in the care cycle of a patient who just finding out that they're going to need a transplant, when do you think the education should start about KDPI kidneys? Because many patients don't hear about it until, they're closer to getting a transplant, or even when they're called with a when they finally get a kidney. So where do you think that education should start? When the patients have CKD and we start talking about treatment modalities?
I think you have
Later.
answered your, Miss Susan, you have answered your question. The day you are going to sit down and discuss kidney options with your patients and transplant comes up, I think it is very important to bring these things. And it depends on patient, right? If it's a 20-year-old patient in front of you, you're not going to say that, let's give you a 85, KDPI kidney. On the other hand, if it's a 55-year-old diabetic whom is not going to do very well on dialysis, you have to sit down and explain that any kidney comes your way is better than dialysis, right? So you spend a lot of time discussing these things depending on who's the patient in front of you. Sometimes we say, even though here you go, that we are saying you take high KDPI kidney, we tell them about dual kidneys. Sometimes we'll put two kidneys for you, unblock kidneys, things like that. So all these things have to be taught, but again, they can only be done if our nephrologists are also well versed of this data. So one of the things that we are doing in association with ASN is to make sure that we can bring more of transplant to ASN, the ASN meetings, which will be helpful.
Very good. Well, thank you so much. Actually, I just think that it's such an important topic, and I think a lot of transplant, even dialysis facilities, are not educating patients maybe really upstream because, not in the detail of knowing about KDPI kidneys. So thank you. I think there is one more question. What is the disadvantage if a younger patient receives a high KDPI kidney?
So,
And if you want to answer this question, so it's, as I said, it's a reflection, the high KDPI. Sometimes if you look at the numbers, that's mean probably, can you hear me?
Yes.
Yeah, that's means sometimes that the kidney may be coming from old donor. As I said, if the 20-year-old patient, I would not offer him a kidney coming from, a 50 or not a 50, like, 60-year-old recipient. The reason for that, because this kidney, will not last as long as the younger kidney. And if you look through UNOS, and again, it's not that accurate, but high KDPI kidney, the half-life of the kidney is not similar for low KDPI kidney. So again, you don't want, a person who's 75-year-old or 70-year-old patient, the most thing you want to do is take them off dialysis or take them off the list. But for a 20-year-old patient, the best thing to do for him is trying to find him a kidney that lasts for long.
Thank you, Dr. Cassia. Thank you, Dr. Anand, for putting that link in there. Somebody asked about a patient-facing handout. So for in-center hemodialysis patients. Thank you so much. Thank you for joining the call, everyone. A big thank you to our presenters for sharing their experience, their expertise. For our participants, please be sure to reach out if we can support you anyway. Before you, as you sign off, you'll be getting a post-event assessment. We would very much appreciate if you can do that. And please let us know if there's anything else we can do for you. Thank you so much for joining this call. And thank you, doctors.
Thank you for the opportunity.
Thank you.
Thank you for having us.